Hi everyone. Good morning, good afternoon, good evening, wherever you are joining from. This is me, Cecile Burrell. I'm chairing this session. Thank you very much. We give a minute to join other attendees, then we will proceed the webinar. Once again, hello everyone, those who joined recently. My name is Cecile Burrell. I'm very honored to chair this important session. I work with Herd International and have been involved in research for the last 2 decades. My research primarily focuses on health systems, multidisciplinary areas, community engagement, antimicrobial resistance, and more often, gender equity and justice. Um, it's truly a pleasure to meet you all virtually. I'm also a proud member of GEAR Up Consortium, which basically focuses on gender equity and antimicrobial resistance. This sessions brings us together around a topic that not only scientifically urgent, but also socially very vital, animal health and antimicrobial resistance, and more on how do we apply gender and equity lens in addressing antimicrobial resistance issues in animal health, livestock area. We all know too often AMR is framed very narrowly as a biomedical issues, requiring a biomedical solution, which is true, but it cannot really achieve the objective, ignoring the social aspects of it. So the social aspects, behavioral norms, the economic pressure, and the unequal power dynamics, these are very important while we address AMR technically. And it is more important in animal health science, where the role of gender inequity has long been ignored or overlooked. In this backdrop, today's webinar is timely and very essential as it highlights how the social and behavioral sciences, particularly gender inequity analysis, the research framework, are critical yet to underrepresented in AMR solutions. So in AMR, especially in animal health, these lenses are often reduced to very limited areas, like, for example, knowledge, attitude, and practice studies, or awareness raising programs, or the training program. But the focus of this today's webinar is more on how we could be more inclusive, more grounded, more effective in terms of delivering strategies that are contextually tailored to the existing context with a greater participation and inclusion of the groups. I also encourage you all to participate actively in Q&A session. We have really exciting time where we all bring our experience. This is a valuable space we have created in this webinar to share your experience, reflections, and practical insights from different regions and sectors. So with that, we have 2 presentations today, with the opening remarks followed by 2 presentations and Q&A session, and there's a closing remarks. So with this note, let me now warmly invite Terry Collins to deliver the welcome remarks. Terry, over to you. You,
I think we may have briefly lost Terry Sushil, so
oh,
let's try and get her back. Um,
whilst we try to connect with her, yeah, let's give a minute if we can. get to her. Meantime, Beth, would you like to share the agenda item, the slide that you shared earlier? Since we lost connection with Terry, we can try to connect with Terry later as we continue. Just to utilize this beautiful time that we have, let me invite our first presentation, which is on gender antimicrobial resistance, focusing on conceptual framework for researchers working in livestock systems. Alestra and Fiona, please come in.
Hello, everybody. This is Alessandra Gallier. I work at the International Livestock Research Institute, ILRI, based in Nairobi, and I lead the gender team. Fiona, do you want to introduce yourself as well now?
Sure. Thanks, Alessandra. So I'm Fiona Emden. I'm a veterinarian and a researcher at Global Strategy Lab, where I assist with some of the One Health work. And I was lucky enough to assist Alessandra with this project.
Thanks, Fiona and Alessandra. Now I see Terry joining us. Can you hear us? Hi, Terry. No. There might be some technical issues here. Please go ahead with your presentation. We always can come back with Terry Collins.
All right. So as you see, we worked on a framework on gender antimicrobial resistance. So I give the first 3 slides, and then Fiona will introduce the rest. Can we move to the next slide already? Fiona, did you want to add something specific here?
No, I just had this more as an introductory slide, and also thankful to Arshni and Susan, who helped us with this project as well too. So
exactly, wonderful. And I think Arshni is at least Arshni I've seen in the among the attendees, so we can also pull her in if we need the support. So this actually was a paper that we published, right? So today we are introducing the paper with Fiona, as we said. Wonderful. So next slide, please. So just very much, I'm going to give an introduction about what we did and why, and a little bit on gender and AMR. So what we developed is a framework that really is a paper in this case that includes key gender questions that any researcher working on AMR may want to utilize in their research if they want to develop gender responsive AMR approaches. So, but of course, the question is but why do we need to care about having AMR approaches that are gender responsive? And there are 2 main reasons to do that. One is because gender norms and dynamics affect exposure to pathogens. And 2 is because gender dynamics and norms really can affect the effectiveness of the interventions to reduce AMR. And I'll explain why. Next slide, please. So in terms of exposure, gender dynamics and norms really affect basically the division of labor in the household. And this, whether you look after the sick animals, whether you clean the pen, they all affect who is exposed to the pathogens. But gender dynamics and norms also affect who takes decisions, about, for example, the use of antimicrobials or alternative remedies. Also, gender dynamics and norms affect who can use access resources. So, if you have no control over the money, for example, you may be unable to buy alternative to antimicrobials in case you wanted to. But also they affect access to opportunities. So not everybody will have access to new technologies. Maybe they haven't heard about them. Maybe they can physically not get to the shop or to trainings. And at the same time, because of what I just said, gender dynamics and norms also influence the effectiveness of the interventions. Because, for example, if we want to introduce an alternative to antimicrobial, and we talk to the person who is not in charge of animal health, surely this person is unlikely to be able to adopt the innovation that we are recommending because they are not in charge of animal health. So we really, unless we understood who is doing what in the household, who takes decision and so on, unless we do that and we target the right people, our interventions are unlikely to be effective. But there is also another very important point, that if we do not have a clear idea of the gender dynamics and norms in the household, it is possible that our interventions increased the gender-based disadvantage, which of course is a bad thing in itself. But also in our experience, when somebody in the household really is disadvantaged by a new innovation, because maybe there is a new breed of cow or a new antimicrobial drug, if they find, for example, that their labor increases enormously and they don't see the benefits of this work, in the long term, they are going to undermine the innovation. And so again, it's an issue about effectiveness of the intervention. And I want to just go a bit deeper here. When you go to the next slide, please. So what we did in the framework, we split between integrated and strategic research questions. Now, you could also look at them under accommodative and transformative if you're familiar with the gender language. But, at the moment, we stick to integrated and strategic, and we can talk about the accommodative and transformative during the question and answer if you want. So if we stick to integrated and strategic, the way we frame them in the framework, when I said, we need to ask gender-related questions to enhance the effectiveness of AMR interventions by targeting the right individuals. Really, this means you need to understand, for example, who is in charge of animal health if you're coming in with an alternative to antibiotic, because you need to understand who is in charge. So that person, you talk to that person is in a position to actually adopt the innovation, right? However, this may create some problems in the sense that if we integrate gender questions to make sure that our interventions are basically reflecting the current situation, the way things are organized in the household based on gender dynamics and norms, there is a risk that we increase or we reproduce this same status quo, and therefore we also reproduce the gender-based disadvantage in a household. So a practical example, if we give information and new innovation to the person in the household who's already taking all the decisions and having access to information and controlling the money, because we know this is going to be more effective, it is very likely that in the long term, we're actually increasing the gap, because we are reproducing and reflecting the existing gap. So what we have done, we also introduce in the framework some strategic questions that are more about, okay, how can we then not just identify gender dynamics and norms to improve the effectiveness of AMR interventions, but how can we leverage AMR interventions so that we actually can benefit and empower everybody in a household or community? So in this case, the question would be turned and would be more around which livestock producers are willing but unable to use, the antibiotics, for example, and how can an AMR intervention support them? So the framework is organized around integrated and strategic. Fiona, the floor is yours.
Thanks, Alessandra. Okay, next slide, Beth. So I think Alessandra's done a great job of kind of introducing why we undertook this project and kind of who would be affected. And so I'll just go into a little bit more detail about the actual methods and show you some examples of the work we produced from this. But for our methods, as also Alessandra kind of did a great job overlining, we had previously conducted a narrative review that identified kind of some key entry points for gender dynamics that could impact AMR in the context of agricultural systems. So what we came up with, which I think Alessandra did a great job going into there a little bit too, but was that there are gendered impacts of antimicrobial resistance exposure, gendered antimicrobial use in general, and gendered outcomes of antimicrobial resistance infection. So we took those entry points that Alessandra mentioned, and then we used this information and analyzed it with another existing health systems gender framework, which was developed by a research team. And we applied this health system analysis gender framework to like the context of agricultural systems that we were looking at. And so combining these insights, as Alessandra mentioned, we developed this list of research questions. Next slide. And I wanted to show briefly what the conceptual framework we developed to look like. So in the center there, you can see in the blue, orange, and yellow, we have those 3 gender entry points, which are impacted more broadly by these kind of 2 outer rings that we have, which we pulled from, the health systems gender framework that exist already. So within the 3 that I mentioned, so antimicrobial resistance exposure, antimicrobial use, and then antimicrobial resistance outcomes, all of these would be impacted more broadly by gender norms, access to resources and opportunities, division of labor, and everyday practices and decision-making opportunities as well. Next slide. So using that conceptual framework, that's how we developed this list of comprehensive research questions. And given the limited understanding of how gender dynamics and norms influence AMR, because this is still a very novel field, we primarily proposed like qualitative exploratory questions. And I think Alessandra's already done a great job of kind of explaining how we separate these out into integrated and strategic questions. But we did want these integrated questions to offer that deeper understanding of gender dynamics and norms in livestock systems with the aim of improving them. While the strategic questions obviously were focused on gender-related issues in livestock as entry point. And I think we have too many questions. Obviously, you can see this is just a quick screen shot of how many questions we generated, but to go through. But I thought I could give a few examples of how they could be applied to specific research settings. So, for example, in a low intensity, if you were completing a research project in a low intensity cattle production system in Tanzania, for example, in that context, men and women would both be actively involved in animal health management and have similar levels of disease knowledge. So the questions that you would consider might be different than a research project being done somewhere else. So some questions that might be considered would be, why do cattle producers of different genders choose one vaccination over another? Are there gendered risks that influence this selection? And what opportunities exist to enhance vaccine uptake among cattle producers of different genders? And next slide, please. And then in contrast, if say you were undertaking a project that would be looking at low intensity poultry systems in Tanzania, which would be predominantly managed by women, the questions that you would consider or apply from our framework would be different. So things you could consider would be which women poultry producers are interested in using vaccines but face barriers in doing so, tying back to the example Alessandra gave, who controls access to vaccine related information and what are the reasons behind these information gaps, and how can access to vaccine information be improved among women poultry producers, just as kind of quick examples. Next slide, please. So definitely as gender analysis in livestock research gains prominence, there is an increasing expectation that researchers are integrating gender considerations into their work. So we're hoping this framework will just provide a useful starting point for researchers aiming to enhance gender inclusivity and considerations in their research. And again, this framework is kind of one of the only ones that I've seen so far that has focused on agricultural systems or livestock systems and is operating in that space. And we're hoping the next phase of our project will involve applying this framework in the field. And then we can additionally further refine it and validate it after applying it to a field-based project as well too. And I think that's everything from me. So I'll pass back over to Cecile.
Thank you very much. Brilliant presentation, really. I learned quite a lot in terms of gender analysis framework in animal health. For those participants who attended lately, this is a webinar. We're talking about animal health and antimicrobial resistance and discussing why a gender inequity lens is key while undertaking research and also contributing how it contributes to the wider mainstreaming of gender inequity in animal health, by asking right questions, using right framework, and there's practical experience. This is me again, Cecile Brau. I'm the chair of this session. Information is there is a Q&A chat box. Those people who have questions, please put your question in Q&A chat box. So our speakers, as well as the panelists, will respond to the question. Let's make it more interactive, the Q&A platform, where we will have more experience from different walk of the life from different regions. I really appreciate use of the chat box function here. Great. Keep your questions posted. We will come back to you, and there's a Q&A session where we will be discussing more questions and experience from all of you. Let me now invite another presenter who is talking on One Health approach tackling the antimicrobial resistance and why gender matters. And this is a finding from a community study in Tanzania. Let me welcome Violet Varsa. Please, floor is yours. You are on mute.
I am muted. All right, unmuted now. Well, hello everyone, and thank you very much, Sushil, for giving me this floor, and to Kate and all the organizers at GEAR for giving us an opportunity to discuss what I feel is just very under-researched areas that are completely critical to interventions or to addressing AMR, which is a rising and hugely global issue at the moment. So my name is Violet Barasa. I work at the Institute of Development Studies at the University of Sussex, where I lecture and coordinate the MSc in Sustainable Development. I have done a lot of research for the last 10 years, looking at gender and health outcomes in low-income areas, so low-middle-income countries. My particular focus is in Eastern Africa, Tanzania mainly, a little bit of Kenya, Ethiopia, and India at the moment. I have collaborated on various AMR projects with the WHO, with one of the latest WHO publications, which has a gendered analysis of vaccine interventions in reducing AMR, which I believe is one of the very first papers that has focused on gender, and we were very fortunate to be asked to work on that. I also must say that it's a beautiful coincidence that I was invited to speak with Alessandra Gallier, who we worked together around 10 years ago in the International Livestock Research Institute, where she works currently, and we speak the same language. So it's wonderful that she went before me, because that makes my work very easy. I might as well close this conversation now, because she said most of the things that I would say. But nevertheless, I am going to, a lot of what I would say will overlap with what Alessandra and her colleague have talked already, but I'm going to give a bit of an understanding of how you can apply her framework in a real study, in an empirical study, which is what this paper is about. So this is also a presentation that's based on a paper that I published last year from the field research. Next slide, please. I'm going to rush through, because Alessandra already spoke about why we need gender. So really, we must know, and I think everyone here knows, why gender is critical in AMR work. So I won't spend much time on it. I think I will spend a little bit of time to talk about marginalized populations and what happens there, why it makes it difficult to have these blanket approaches that do not look at social and other cultural drivers of AMR instances. And I will look at why a One Health approach could be critical, could be important. At the moment, it's probably not taken advantage of, but it could. And then I will look at some findings. Next slide, please. So we have had from our previous presenter that gender is important, it's an important consideration, and that when we are looking at gender in health, generally, not just AMR, we think about the gender and sex differences in vulnerability and susceptibility to health issues. We think about anatomical and biological differences and behaviors that make certain diseases more, the exposure of certain diseases more likely to happen to men or women. For example, for women, we know that changes in the immune system through pregnancy, childbirth, menopause, and so on impact women as a group differently. And this is a global phenomenon. It's a biological, sex-based phenomenon that we can't change. We know that behavioral patterns, for example, compulsive behaviors, addictive behaviors, and things like smoking, men can be are more likely smokers than women, particularly in countries where women's smoking is frowned upon, for example, in Southeast Asia. And for that reason, there has been evidence that there are disease distribution patterns that also reflect these gendered behaviors. For example, respiratory infections being likely higher in men in Asia and the Pacific, where more men smoke than women. Alessandro talked about gender norms, and I just want to also highlight the fact that norms and responsibilities and roles change across place and time. And we have some research that shows, for example, gender bias in childhood immunizations, in nutritional patterns. We have community societies where boys are favored over girls. If children are sick, boys are more likely to be taken to treatment, to hospital. Girls are more likely to be treated at home with antimicrobials, including antibiotics. We have seen this research in places like Pakistan, Cambodia, Nepal, and poor responses in Bangladesh, and I'm sure in other parts of the world as well. Next slide, please. When we think about gender analysis, which Alessandro's framework very well highlighted, you can't assume these things. You need to do an in-depth ethnographic work of gender and livelihoods. You need to think about who to talk to in communities, in settings where gender then is complicated or intersects with cultural norms of the place and even economic patterns. So you think about decision making in the household, who makes decisions. Don't always assume that men always make decisions. In some cultures, women can make decisions around resource and resource use. So this intra-household and extra-household power dynamics. A household is one, but then there's also other influencing households within the community. For example, extended family, uncles, aunties. Some of the structures of living, for example, we did some research in Pakistan, in the south, where a single family, a nuclear family, meant nothing because decisions around resource use was made by the extended wider family of groups of people living together who are bound together by family. So mother-in-laws and older family members made decisions for younger couples. And so understanding who makes decisions also helps us to know whether decision-making around use of medical resources and interventions in those decisions can impact certain members of the family and not others. And so it impacts how people interact with health and health interventions, from where drugs are obtained or bought, to with whom and dosage and who takes them and when, and issues around trust and credibility as well. Next slide, please. Now, I think that my research focus was on health-seeking behaviors and health outcomes around commonly occurring diseases. And as an entry point, then I wanted to look at what drives people to seek health or healthcare, and what healthcare are sought, and is there are there gender differences? Do these patterns that we've talked about, these norms and these roles and responsibilities and preferences, do they also play a role, as we would assume, in the health-seeking behaviors or how people approach healthcare? And social drivers of health seeking have been well established in low and middle income countries. And we talk about low and middle income countries because these are contexts where there are huge health inequalities. There's no universal health coverage. And so health seeking becomes a part of entry points into wider structural inequalities. So we know that in the context of low and middle income countries, particularly rural areas, that women are required to be, in some cases, not in all cases, but in many cases where resources are scarce, women may be required to be accompanied to seek healthcare. Certainly this is in my own research across board. You'll find, for example, in Muslim communities or in pastoral communities or in rural areas in parts of sub-Saharan Africa, men, usually husbands, dads, and father-in-laws accompanying wives and daughters or moms to the healthcare provision centers. Men are supposed to know the symptoms automatically, so they would explain the symptoms and they can often negotiate a prescription with care providers. And usually it's done because of gender norms and dynamics around who women can speak to and whom they can't, particularly if the healthcare providers are male. Usually, for example, in Muslim communities, in rural areas, I have seen this in Pakistan, I've seen this in Bangladesh, I've seen this in Nepal, that women cannot speak to men, and so the husband or the male guardian will explain, and usually they will explain the symptoms. And women and girls in many of these areas who need male permission to use healthcare services can delay health seeking if the male guardian is not available. If they go with a male guardian and the man explains the symptoms, it can be mansplained, and so it can lead to misdiagnosis. It can lead to misprescription. The man can actually ask for a particular prescription. They can ask for antibiotics, for example, even without testing, and even when the woman probably doesn't have a pathogen or bacteria that requires antibiotics. But because the man has asked, this can be given because they are negotiating the treatment for the woman. We also have, in the community settings, a lot of this lay diagnosis of disease, and so lay versus official medical diagnosis. We see that gender differences in knowledge can vary across location and across age. And so what this means is, for example, a woman is sick, she lives within a wider community, her mother-in-law comes around and says, I think what you have is this disease. I think you are displaying symptoms of pneumonia or of UTI, and I think you should take this medicine. So this lay diagnosis based on a repertoire of historical knowledge around symptoms may completely get it wrong. And so women and girl children are more likely then to be diagnosed in this way or misdiagnosed in a lay way and be given drugs that are bought over the counter. And this can really predispose or expose them to drug resistance. It can lead to drug resistance and therefore AMR. And so gaps between men and women's access to healthcare resources and this lay interpretation of symptoms is a key feature of understanding sex and gender differences. Next slide, please. Alessandra spoke about gendered access to antimicrobials, and this is some of the research that came from after COVID, particularly WHO research that led us in the Lancet report, which says that there's widespread evidence of overuse of antibiotics worldwide, and this may exacerbate the spread of AMR, as we know. For example, during COVID, 75% of patients were treated with antibiotics just in case. So this is again talking about this huge rise in the use of antibiotics unnecessarily, which is driving the AMR problem even further. And of course, a lot of these patients being treated with antibiotics without testing or just in case would have been in countries where testing for COVID was lower or there were no sufficient infrastructure and this would be again in LMICs, unfortunately. But few studies have focused on gender determinants of the availability, access, and use of antimicrobials. And I think it's quite a shame because life has gone on and study upon study have produced these evidences of a huge rise in AMR, but few studies look at the disproportionate distribution between men and women of impacts across gender and across age. We have this across countries, but we don't have this distribution across genders, which is what us of people who really want to bring the gender issues on board work on at the moment. Next slide, please. This is the last slide on antimicrobial use before I go into the study. And just as I talked earlier about the health, the drivers of antimicrobial use, we also have these health workers' attitudes that are usually shaped by existing gender norms. So studies have shown, or women have spoken to us, talking about insensitivity and disrespect towards female patients by healthcare staff. Pregnant women, when I've interviewed them, they've said to me, as soon as we get there into the hospitals, we don't want to go to hospital because when we get there, we are told, just go and take paracetamol, just go and take antibiotics because what you're experiencing is normal. So there's a lot of insensitivity around women's health in general, and this permeates through into health facilities, particularly in lower income quintiles, because women's health is not taken as seriously as men. And so these attitudes may impact women's exposure to antimicrobials and necessary use of antibiotics because they're sent home and then they have to probably obtain medicine over the counter and self-administer. There's also overprescribing of antibiotics based on gendered assumptions around infections. So sometimes women are given, they're prescribed more antibiotics than men because women's illnesses or health is assumed to always be bacterial infections. And apparently in some cases, in some places, men's infections are assumed to be viral at the beginning of the medical examination before they are confirmed by tests. And I don't know why that is. It might be because women's life course, across the life course from when women are young adults to maybe premenopausal, they're more predisposed or more likely to have bacterial infections than viral. I don't know. I think the medical people can explain that to us. But it's just alarming that women would be overprescribed antibiotics than men. And this has been consistent. There has been consistent evidence that show this. And so, as I said, pregnant mothers are a key vulnerable group who are likely to be given antibiotics. Spirit children, which is a term we found in West Africa, which is children who may be displaying out of the norm or neurodivergent children who would medically be on the autistic spectrum, can be misunderstood in the medical diagnosis, and usually in the communities they are then labeled spirit children because they're out of the norm, and these children will continually and routinely be given antibiotics week after week to try and cure them of this neurodivergency. We also see elder women as a vulnerable group in many circles being given a lot of antibiotics, and teenage girls navigating teenagehood and hormonal symptoms are also given a lot of antibiotics, as well as young mothers. Women are bullied into accepting certain prescriptions. They are told, I think you have a UTI, I think your pregnancy, your symptoms are like this. Even if women say, I am feeling these symptoms, they can be steered towards certain symptoms and asked to accept a prescription, so they're not listened to. And so this diminishes trust in health systems. Women don't want to go to healthcare settings, which leads to prolonged illness. And then women would just go and buy medicine across the counters, and usually antibiotics. And it also affects the adherence to treatments, which increases, of course, the potential of developing drug-resistant strains. Next slide, please. So why do we need a One Health approach in tackling AMR? And I will come in my setting in a minute, but we need a One Health approach because One Health over-encompasses, it looks at the various disciplines and sectors. It brings together more than one sector. It says disease is biological, as is social, as is environmental. And so we need all these actors to come together and chart a path for intervention. They also recognition that it's the intersection of poverty, really, and its determinants, poor sanitation, lack of clean water and hygiene, that increases AMR. So not one sector can actually address the problem of AMR on its own, because AMR is not linear. It's an intersection of very many things, and poverty being one of them, and its determinants. In livestock keeping communities, for example, in Southeast Asia, in Sub-Saharan Africa, you get these habitat overlaps between people, livestock, and the environment. And this can enhance disease spillovers, and delay or inappropriate treatment can lead to development of AMR. The structural inequalities are the intersection of poverty and its determinants, which means no single sector can address a health challenge or health challenges. And AMR is a perfect example of structural factors that intersect with social and cultural factors to produce different risks for different people based on their gender and on where they are. So One Health approach recognizes that all these intersections and sectors, these things bring together people, humans, animals, plants, the environment, you name it, into this collage of a bubble that, not one person, not one sector, not a medic can get them out. We need social scientists, we need engineers, we need medics, we need animal health scientists. We need all this to bring about meaningful change. Next slide, please. So what I'm going to finish off now is to look at some of the stories from the field. So this paper, which I published last year on pastoralist experiences with antibiotic resistance, which is titled The One Health Approach to Tackling AMR, and you can read it later. I will just highlight some of the key findings and some of the key stories. Next slide, please. So just a little bit to introduce the study, the sites of study. I worked among nomadic Maasai and Warusha pastoral settings in northern Tanzania. I worked in 4 villages, vast pastoral villages with a population of around 3,000 people spread across the Maasai steppe, very rural, very remote. I was trekking at least 60 kilometers a day with nomads, following them and understanding their everyday lives, and if they fell sick and they were going around with their livestock looking for water and pasture in a very arid, semi-arid ecosystem where water, sanitation, hygiene facilities are almost non-existent. Health facilities formally are completely non-existent, and documenting their own experiences with, if they fell sick, where did they go, what did they do, and understanding the gender dynamics that made this society function. So I interviewed across 12 months, 379 participants, 100 women and 200 men. And I looked at women's roles and how their roles versus men and boy children's roles may have predisposed them or routes of exposure to disease, and how they would approach health seeking. So just to say that, as we probably know, pastoral and agro-pastoralist societies or communities across Africa, across Asia, talk about Mongolia or West Africa, is always the same, that they live in some of the most remote, most hard-to-reach areas in the world, and is usually characterized by poor public health infrastructure that results in limited interaction with formal health systems. Next slide. So just a little bit of a picture of the areas that I worked in. Extremely poor, gender roles are very, there are very strict gender norms, and society is organized around age and gender. So women's roles and men's roles are pretty distinct. When children grow up, boys take over certain roles, and usually the roles involve looking after livestock or cattle. Women and children, their roles involve taking care of the household, taking care of sick children, sick livestock, and managing the homestead. And men's role are to look for pasture and resources for the livestock. So livestock are key because livelihoods are surrounded by livestock as the means to livelihood. Usually, the distances between villages and households are very vast, and distances to urban centers are even vaster, they're even greater. There's a huge over-reliance on informal health systems, so drug peddlers and informal drug sellers are very common, and they're usually the first point of contact between families and a healthcare system, usually by buying and sharing medicine within households. And so, for example, it was at least 50 to 60 kilometers to get to an urban center from the village. There was a small health center located 14 kilometers from the nearest household. And so people would only go there if they were really, they had severe symptoms and they were not responding to antibiotic home-based treatment. Next slide, please. In terms of why Tanzania and why this place, you can obviously tell the reasons. It's because nobody would probably research in places like these, so they're extremely marginalized, severely forgotten, and usually operating with huge constraints. But in the context of Tanzania itself as a country, it's pretty doing badly in terms of mortality associated with AMR. 100,000 deaths per year across 204 locations in last year's Institute of Health Metrics report, saying that nearly 100,000 people either died or were disabled by AMR impacts because across Tanzania, and that the deaths from AMR alone are higher than respiratory infections and tuberculosis, maternal and neonatal disorders combined. So it's pretty high up there. However, there's no sex or gender disaggregated data on these impacts of these deaths. We don't know how many women, how many children, how many men. These are just more generalized data because there's no research, and even less focused research is on marginalized communities, including these populations that I highlight here. Next, please. We know that determinants of health are social as are their biological, and this I talked about already. So could we go to the next slide, please? So what did I find in this study? I find what you would expect and what I have already talked about, which is that gender and age continually shape access and use of pharmaceuticals. Antibiotics are the most used drugs, and again, women are probably a lot more affected by these. So the fact that there are unregulated informal drug peddlers, which I talked about, who are usually the only contact between sick patients and some healthcare provision of some sort, because of these vast distances to get to a formal health clinic. People buy antibiotics, usually amoxicillin, which are found to be 75% more common than any other drug. I don't know if they're the most available. I suspect they are. But every household, in at least 75% of my 379 participants, had amoxicillin in the house. And when I asked why they had amoxicillin, they said it's because we always need it, because we have back pains and children are always sick and we can borrow it from friends, so we always have it. Where do you buy it from? where we buy it from the Buanadawa, the drug peddler who comes around every week. Do you know if they are expired? Do we know if they are real antibiotics or counterfeits, real amoxicillin? Well, we don't know because he sells us in unlabeled.
I appreciate, in the interest of time, I think
Yeah.
if you could wrap up your presentation so we save more time for Q&A.
Okay. All right. So what does this do? Of course, this can lead to overdose. It can lead to symptoms being misunderstood and therefore co-infection, and women and children will be more severely affected because they're the ones likely to share these medicines when the men are away. Could I go to the next slide, please? And the next one. There's also what is important also to say that the same medicines are used in both animals and humans, because there are a lot of disease overlaps between what people see in themselves as symptoms and what people see in their animals. And so there could be even more exacerbation of an antimicrobial resistance because people are treating animals with the same medicine as themselves, but also continually using products from these animals, for example, milk. So you could say there's a lot of overlaps there on how drugs interact with the bodies. Next slide, please. Yeah, the discussion one, please. The next one. Yeah. So this is the last penultimate slide, and AMR interventions need to go beyond working with the formal health actors, I think, in this context, to include informal health providers and licensed drug sellers, train them because they're often the most affordable and accessible healthcare providers in these settings. And a One Health approach must include all sectors and work across board, including with non-obvious ones. Last one, please. So we know that we need social science work a lot. We need a lot of it. This is just the tip of the iceberg. There's so much of this that could come out from different areas and different settings that haven't been looked at. And here we are, we have an opportunity to incorporate a well-known framework, including a framework that Alexandra prepared or have talked about, and these One Health approaches. They are very wonderful approaches to fuse together, to incorporate and include some of these under-researched issues, determinants that may be pushing AMR and leading to this silent epidemic. So we need to enhance collaboration between all of us across disciplines, across sectors, to work together to address this. All right, so that will be it. I'm sorry it took so much time. Thank you very much. And I look forward to interacting in the Q&A.
Thank you, Rosa. It's a brilliant study. Thank you very much for presenting to us. It's a great insight. In a number of different ways you have highlighted the necessity of disaggregated data and analytical frameworks that requires to really deepen understanding how gender plays a role in addressing AMR in different brilliant study. Some of the participants joined recently, so welcome again in this webinar where we are talking today how why gender and equity matters in animal health research, taking the One Health approach into consideration. We just finished two brilliant presentations. This is really exciting. There is a Q&A box, so I appreciate if you put your question in the Q&A box so we can direct to the right panelists, presenters to really answer your questions. Do we have Terry back online? Terry Collins?
Alas, not that I can see, Sushil. She's not on the participant list. So I think we might have lost Terry completely. Apologies for that.
That's unfortunate, but we will have another opportunity to hear from Terry Collins, who is from McDonald. This is great. Now we are really entering to our Q&A discussion session. where I appreciate all the participants. Raise your hand, put your questions forward. Oh, there's a Terry's nameless.
She's in with the attendees, it seems, Sushil, so not as a panelist as yet.
Oh,
So when we can move Terry across, we'll bring her in.
okay, no worries. So that brings you, Russell, back to the Q&A discussion. So I appreciate your facilitation to the Q&A discussion session, including with Dr. Natpal Mawanjit.
Okay, thank you very much indeed, and welcome to Dr. Natpal Wenzaki as well from Kenya. Dr. Natpal studied Masters of Science degree at the Veterinary Epidemiology and Public Health in Sydney, and he is currently involved in the coordination of antimicrobial resistance policy and national action plan implementation in animal health under the One Health framework. So that's an extra panelist for us. So others who have questions around that kind of policy area as well in terms of veterinary, AMR and One Health, please pop questions in the Q&A box for that as well. Just to direct people that the Q&A box is on the bottom of the screen between the share and more. So if you have trouble locating it, that's where you can find it. But we do have some questions for the panelists. I think, Violet, you've encouraged the most questions at the moment. So I'm going to start with you, if that's okay. And then if other panelists wish to contribute, please just raise your hands on these areas. So we have a couple of questions. I'll just read them out. I'll read them out one at a time, and if you want to respond to each. So in nomadic pastoralist areas, who is it to go to the drugstore to buy the antibiotics for the animals? So I think some very specific questions around your study, Violet. So go ahead. You are muted, by the way.
I'm always muted. All right, sorry about that. If the question is simply who goes to buy the drugs for animals, it's the man. And usually it's the man, the man in charge of the particular stock that is ill. And this is not always the owner of the livestock. It will be the man in charge. So the nomadic pastoralists are usually they usually live in a communal compound where there's at least 2-3 generations in this compound. And if the most senior member, male member in that compound is still able, they would probably be the grandparents. They will be in charge of addressing animal health concerns. And if the animals are sick or they believe that drugs need to be bought, it will be that man who will go and buy the drugs, bring them home, and show or supervise the administration of drugs by the younger men who may be owning 2-3 cows or 5 flock out of the bigger herd. So the actual person who goes to buy would be the senior most male who is able to in the community.
Thanks very much for that very clear answer. There was also a mention of tests. Who was doing the tests? Do they do them themselves, or is it the vets who administer these tests? And how are they accessing them?
So the question of tests is a complicated one because, again, diagnosis, and I'm putting this in quotes, is based on symptoms alone. And by the time they call in the animal health worker, or Bwana Mifugo, as it's called in Swahili, usually they have tried all sorts of treatment. They've given amoxicillin or antibiotics. They've given, they've sprayed the cow and it's not responding. And that's when they would call the official health worker, animal health worker from the town. As you can see, the towns are very far. These resources, including animal health workers, are located quite far. They're costly, they're difficult to access, and so they'll only go to them in the most severest of cases. Usually, the drugs are administered without testing based on symptoms alone.
Fantastic. Thank you very much. And what do you mean by overdose or poisoning in the nomadic concept? Who administers and do they seek veterinary advice? I guess it's a kind of linked question to the one before.
Well, I just mean that without having a proper prescription or testing to confirm the type of pathogen and the course of treatment, that there are cases or there is potential for overdosing, over administering the wrong medication to facilitate or quicken recovery, as they say. And in many cases, I had that amoxicillin treated faster, so it was seen as a quick fix, and given in higher doses would mean, even in people, would mean people can get back to work quick, faster, can get back to their chores. So potential for overdose is real there because there's no diagnosis, there's no prescription, and also medication is given based on doses that are affordable at the time. There's no full doses, there's no adherence to a full dose because it's not known.
Thank you very much for those answers. I'm going to bring Dr. Natfala in now. I just wanted to understand your experience of who accesses, who buys antimicrobial drugs for animal treat in your context. So am I okay to bring you in on that point, Dr. Natfala, just to get some, if you are still here. I think we might have lost Dr. I think we're having big problems with connectivity at the moment. Okay. From the work that Alessandra and Fiona have done, is this common, or is this very varied upon context in your experience about who's actually going to purchase the drugs for the treatment of animals? Is there any reflections from your position, Fiona or Alexandra?
Which question are we?
So I'm expanding on the question really to get it from other contexts. So I'm really thinking about who actually purchases antimicrobial drugs for the treatment of animals, and then who provides that treatment. So is that very varied across contexts, or is it generally the same gender who purchases and delivers the treatment? I'm just wondering if that was any commonalities around there.
Yeah, so in my experience, and we've done work now in a number of countries, it's a bit like, I think when you look at gender dynamics, there are some patterns that really seem to apply in many, many places, let's say, and then some within those general patterns, some local specificities. So, for example, the general pattern that we see is that women have limited mobility, especially the younger women and the older women, compared to men. So when it is about going to purchase the vaccines or any animal drug, usually it is the men that do that. And we also see that generally unrelated women and men cannot interact in so many places, and which means that women cannot call vet, and vet are very often men, and male vet cannot go to treat the animals in a woman's house unless the man is there. So again, it is very difficult for women to get access to animal health services. Very often in Ghana, we ended up employing women vets, which were not, by the way, the government didn't have any women vets employed. So we employed them privately to make sure that the women then would get access to animal health services, including the medicines. But then in terms of who injects or, who is in charge of animal health, I find that, dynamics then change depending on context and household. So there are these big patterns in terms of mobility, interaction between unrelated men and women that really we've seen in so many places. When it's about intra-household dynamics and norms about who does what, they vary between locations and even within households. And I hope that helps a bit.
No, thank you very much. It also brings up the interesting point about the role of gender on those providing information and services to veterinary services and information. There are other areas where gender of the treatment providers or information providers drives behavior in different gendered groups.
I don't know if Fiona wants to take any of those. Fiona, did you want to come in?
Whichever one of you is fine. Yeah.
I mean, I definitely think that is the gender of the animal health providers plays a huge role. And I think Alessandra kind of mentioned that and how that ties into especially female producers being able to access their services in a lot of different areas. But outside the context of animal medicine, we know that like prescribing practices change depending on the gender of the prescriber as well. And for sure, those I would assume that translates over to veterinary medicine as well too, and the context of the gender of the person accessing the antimicrobials and the gender of the prescriber. When we look at like human physicians prescribing for females coming in to seek antibiotics, will change like how they're prescribing. So for example, like women were much more likely to be prescribed antibiotics in a lot of different studies looking at human prescribing. And I can only imagine that also plays a role when we look at veterinary prescribing as well too. But I think there's just probably less studies looking at that overall.
And do you think conversely that kind of disproportionate gender representation in certain roles would drive someone seeking behavior to other areas where there's more gender diversity in the roles?
Yeah, I mean, maybe I'll pass a little bit back to Violet after this, but because she can probably touch on that from her project more. But yeah. I definitely do think that, I mean, as Alessandra said, in the context of Ghana, where they had to pay for to have female veterinarians be employed by the government, I think there are certain fields where we see like one gender dominating more than others. So I know like in the context of like rural areas, we'll often see more male veterinarians than we will in urban areas. There'll be a higher proportion of female veterinarians. And obviously that would impact in the context of the examples that Alessandra said, where, you know, women would be less likely to interact with a male outside of their household. That would change the dynamics of where they're getting their medications. And in areas where, you know, where we see a lot of access to antimicrobials through informal suppliers like drug sellers, agro-vets, that sort of thing, you know, accessing the antimicrobials through them as opposed to talking to their animal health service providers would definitely be something that would potentially be more common in those contexts. But maybe Violet, from your studies, you've come across something like that as well too.
Thanks very much. Over to you, Violet.
Well, thanks both, and I think it's exactly that my research has been more on the human medicine side, where we see, of course, more women being steered towards more informal providers because they're more sympathetic, they're less insensitive, and they can have a chat. So more women going to lay doctors or approaching senior or older family members to talk about symptoms and to arrive at a diagnosis, rather than going to the formal health clinic because of the insensitivity, the attitudes and the disrespect that they mention facing. So these are facility-based barriers. I imagine this being very much the same with animal health, particularly if women are in charge of livestock in cases where they are actually, because they are in charge of small stocks health. For example, sheep and goats and even poultry, women are in charge of their health. And so when chickens are sick or they need medicine for poultry, usually they would go to the neighbor's house to ask what they use rather than call the aggravate guy, because they're not allowed to speak to men on their own, or the gender biases persist and these norms around who you talk to, and the fact that men aggravates may not be as accessible, as responsive, or may diminish women's explanation of symptoms and force that diagnosis on them. So there's a lot of mistrust and lack of credibility in official health providers, animal health providers.
Can I come in again?
Yes, please.
just to give also, absolutely, I totally agree with what has been said. And I think it's really interesting to see how, for example, going back to the case of Ghana, there were two key norms, gender norms, that we really thought were the root norms of a lot of other gender norms that were really disadvantaging women and their access to animal health. So one was the idea that women are not supposed to interact with livestock. This was in the communities we worked on in northern Ghana. And the other one, and the idea that associated to that was because women, when they are menstruating, they actually, if they get in touch with the livestock, they will kill the livestock. Yeah, so that was the first norm. And the other one was that women should not ever declare that they own an animal. Yeah, and this had huge consequences. So the fact that women should not interact with livestock because, you know, in case they are menstruating, they kill the animal, meant that women could not work as vets. One, because, you know, it's very hard for women to get into vets in veterinary as a discipline, because, you know, that's the idea. And then, of course, nobody will hire them ever because, you know, in case they're menstruating, they didn't say anything, they'll get into the, you know, the farm and they'll just kill all the animals. And then kill, I mean, you know, because they're menstruating, the animals will just drop dead for some reason. And the other one was the one that women are not supposed that they declared an animal, that declared that they owned an animal. That had huge consequences because the women said that even in cases where they put the work in the animal and they bought the animal, they wouldn't see any of the benefits, because the moment the animal was sold, they couldn't claim any of the income. And even in case, you know, unfortunately the husband died, the brother-in-law would come and claim all of the animals. And this is, you know, had so many repercussions. Just to give you one example, is that when women, in some cases, when they called the male vet actually said, we wouldn't just go and support the women, first of all, because it would be an issue about them being unrelated, but also because they wouldn't trust that, one, the women knew about livestock, because, you know, women and livestock are not associated, and two, they wouldn't trust that the women would have the money to pay for their services. So you really see an overlapping of all these gender norms and gender dynamics. They really create a system of disadvantage that, you know, it's really has so many repercussions. You know, I could keep going in terms of what were the consequences. Yeah. So what we try to do, and this is something we are studying at the moment, is really trying to identify the key root norms. Like in the case of Ghana, we really thought there were two root norms, and we realized that when you start addressing the root norms, and you're successful, and that's possible, then, you know, also some of the other norms will start, you know, breaking apart and opening up opportunities for, you know, new access to animal health services, or even, you know, working as a woman, working as an animal health service provider. Thanks.
Thank you very much indeed. There's loads of questions now, so this is absolutely fantastic. For those that are in the chat, because we're limited on time, hopefully the presenters will be able to respond to the others and we can send them out afterwards, I'm hoping. But I'm going to use this opportunity, as Terry from Mott MacDonald was not able to come in earlier for her remarks. Terry has posted some couple of questions. So Terry, would you like to ask the questions? That'd be great.
Oh, sincere apologies to everyone. I had real connection problems this morning. And what I was hoping to do at the beginning was just to frame some of the discussion today within the Fleming Fund, and just to reference the fact that we, of course, in the design of the Fleming Fund, have been working collaboratively across sectors to tackle the global threat of AMR. And while we've been doing that mostly through surveillance and antimicrobial stewardship approaches, we have, as an embedded principle of the Fleming Fund, been applying One Health approaches. And we've also understood from the outset of the programme how important it is to mainstream gender and equity across all our programme activities. And we've been working really proudly with GEAR Up over the past 2 years to push forward on that endeavour. And it is, as we've heard today, quite a complex and challenging task. So it's been fantastic to see this all unrolling, and it's complex and challenging, partly because we work in the Fleming Fund across 22 different countries, 22 different contexts. And as we've heard today, context is all in all the work that we do, and AMR is of itself a multifaceted and complex challenge, as we know. And I think it's been really interesting as well that we've tried to be tapping in on the Fleming Fund to the fact that while we're applying a One Health approach, we need slightly different, more nuanced approaches in the animal health sector to the human health sector. So to hear a discussion around that today has been absolutely fantastic too. So without repeating everything I was going to say at the beginning, I just really want to send out heartfelt thanks to all of you for the very detailed and rich presentation of examples and a really handy conceptual framework as well. So my questions that were in the chat were really trying to sort of tap into the fact that we've described context very well, but of course context and culture is not static. And I just was kind of interested in how things might be changing in the Ghana and the Tanzania example, and the role of age differences over the life course might be what that might be playing. So for Violet, for example, are there ways in which children, male children, girl children, interact with livestock differently from adults, older people, male and female? What are their roles? And equally, is there something going on with children who are accessing education? Are they playing a role in educating adults? So really, I'm just thinking about where are the opportunities for change, really. Over to you guys.
Thank you very much, Teddy. Over to you, Violet. 1 minute, and this is going to have to be the last question. So lots of questions. If you could answer them in 1 minute, that would be superb.
Well, thank you for that question. And I probably need a whole day to explain this study as it is, but sorry, it will be 1 minute. Terry, you're absolutely right. There are entry points for change, and we are seeing this already. So in my study, for example, 18 to 24-year-olds, boys, were some of the most critical drivers of change happening. They were the most likely people or group to use antibiotics, sadly without a prescription, but on their own, without asking these elders or asking male guardians, particularly boys. So this could be a really crucial, and also the drug peddlers usually fell in this age bracket. They were around 20 to 25-year-olds who were the informal drug sellers. So one of my suggestions for policy intervention was these people need to be trained. These people need to be talked to. These young people need to be co-opted into formal interventions, because they may just be the group that we need to enter into the communities and change behaviors. And if we educate them, they're more likely to educate the rest of the community, I think.
Thank you very much. A very hopeful message to finish on. I know that there's lots of questions still remaining. I know, Amos, you've had your hand up to speak. If people put your questions and answers in the Q&A box, we will send out the answers to those questions after this webinar, because as always, not enough time to address all the questions. But thank you very much for participating in the QA. Thank you very much to the panelists, and I will now hand back to Sushil.
Oh, thank you. What a wonderful session. Thank you, Russell, and all colleagues. We are coming to really close to this session. Now I would like to invite Javier Marcos for your closing remarks. I see your beautiful picture with your dog. Really, I like that.
Yes, I hope you can hear me okay.
Yes.
Okay,
Yeah.
thank you. No, thank you very much and for the compliment on the picture. I just wanted to start by saying thank you, and a double thank you. The first one is for allowing me to say some words at this webinar on which from which I learned about its existence not so long time ago, and I was very happy to hear that this webinar was taking place. because I mean, you have already said that, but it's essential to recognize that there is still a great deal in closing the gaps on this issue and the gender inequities provoked. So thank you very much for allowing me to say some words, as well as for all the work that you have done. Not only presenting this, but also for all the people in the field and all the people in the back office making this possible. I'm representing today the World Organization for Animal Health. And our organization, for those who do not know it, it's an organization who is setting international standards for animal health and animal welfare. And something that most of you have already said and that we agree on is that AMR is not just microbes, it's not just the biology, it's about systems, it's about health systems. And whenever we talk about systems, we can consider that there can be inequities, and gender is one of the sources of these inequities. In my personal case, I've been working on this area since the end of 2021, and I've been trying to think. I've been talking to many people, and I've been trying to identify what to do in this area. So during this, I would say 3 years, it's been it's been an incredible period for me to gain awareness of an invisible problem that brings invisible risks and that must be taken into consideration. But for us, and it's my personal will, is to pass on to the action, to do something. What can we do to really start changing things? As an international setting organization, the ideal thing would be to have these gender considerations in our international standards, okay? But to get there, we need the science and the basis on which based on these international standards. And I'm very happy to see some of the work that has been presented, and I think more work should be done. And on that side, I would like to openly make a call for suggestions. Things that WOA, our organization, could do in collaboration with you and with many other people working on this area. Because as I said, we want to move into action and, let's say, I wouldn't say stop talking, but I would say less talk and more do. And on that side, whether it's about research gap analysis, whether it's about the development of guidelines or development of frameworks, doing something on this area, we are more than open to do that. And I hope that this webinar will be just the beginning, or I would say another stepping stone in our way to close this gender inequality. So as some of you have said, we fully agree that if we continue to write AMR policies that ignore gender, we would be making them incomplete, we would be missing opportunities. And this is something that we want to change in that area. So once again, thank you for the space on this webinar. I do not want to take much time. Congratulations to all of you who have done this work. Keep it up, and looking forward to continue the discussions with you, as well as with many others who would like to knock at our door to see what we can do in the next years to come, so that finally we can include these components in the international standards, and we can move into the policy making side. And in a few years, or I would say in some years from now, that we can talk that we have not only improved or contained AMR, but we have done it in a proper way so that animal health systems, human health systems are improved, taking into consideration these biases brought by gender. Thank you very much. Back to you.
Thank you, Javier. Great words. Definitely, I mean, this is a good start to talk about things. But in the meantime, let's translate our talk into actions that you said. A very good call here. Yes, wonderful session. As we draw this insightful session to a close, I really would like to express my sincere appreciation, a big thank you to all the attendees, participants who have engaged in this. critical topic. And I really appreciate your continuous engagement as we work in our own platforms. And a big thank you really to our presenters. Great insight in a number of ways. I wish this webinar would have more longer time to debate, discuss on so many critical reflections that you have made. We will have all the questions answered in written form. We will reach out to the panelists, remaining questions to be answered, and there will be recording of the sessions, and we will also share the slides that was presented today. For me, today's really discussion reinforced a fundamental truth that tackling AMR requires a holistic approach, and that need to be inclusive. That when the gender and equity considerations are made, the transformative actions can be more result-focused, oriented, more insightful, because there is a lot of interconnectedness of human, animal, as well as environment health, as we continue to tackle the One Health framework in our work. I personally have been working in Nepal and a number of other low-income countries, and as part of the GEAR Up Consortium, we have been working across several countries along with the Fleming Fund country grantees and other stakeholders. And one question that was really struck me out of many others is what are the messages to the policy practitioners? How do we communicate this, the sense that we discussed today, to policy practitioners in each country? So the mainstreaming of gender and equity, not only in animal health, but across the One Health approach is delivered, actioned, and contributing to the results. So that's the key question we all, as a researcher, as a policymakers, as an implementer, we need to ask really ourselves. This is not only a matter of fairness when we talk about gender and equity. It's a matter of really a strategic necessity in order to address this in a holistic fashion. So by integrating gender and equity lens in EMR, we cover a lot of disparities, uncover a lot of disparities in terms of access, knowledge. It's a great presentation that we heard today. So moving forward, again, I make a call here, as Javier you mentioned, is getting these researchers, policymakers, implementers, and funders together requires a strategic shift in our routine work and in our mindset. That's absolutely what I experience working with different stakeholders as well as policy entrepreneur in a number of different occasions in health sector. So I think that platform and that change is absolutely critical for us. Let us commit the transforming our process so we have more research focusing on unleashing the realities, ground realities on AMR, animal health, human health, environment health, as well as bringing the policy practitioners together. Once again, well done, GEAR Up team, for really coordinating this wonderful session, wonderful webinar. This is not, final here. We will continue to bring more exciting webinars on different topics by connecting with different individuals, practitioners, policymakers. There is a QR code. Please join our community of practice. I appreciate having more people on this. So once again, thank you, everyone. Have great time ahead, wherever time zone you are in. I bring this session to a close. Thank you very much.